Thank you for coming. This is a very exciting time, I think, for ophthalmology. This slide is really to screen out any of the people with epilepsy, and I'll stop it flashing in a moment when the epileptics have gone. Okay, I have been in the field for a very long time, unfortunately, and it was my patents that founded Summit Technology, and that was the first company through the FDA for refractive surgery. And I have always been concerned about protecting our patients. Now, these are my financial disclosures. Okay, so let's start. All of you here will have signed the Hippocratic Oath, and I'm hoping that it's not the Hypocritic Oath. This was founded back before Christ, and the whole concept here was do no harm. So none of us want to introduce a harmful technology to patients. The real advance over the past several thousand years has been the concept of personalized medicine. Now we can elect to treat patients specifically in relation to their individual genetic makeup. And so we can define an individual on the basis of their genome. And this has been a huge revolution the past few years and has a dramatic impact in our own field in relation to diagnosis in common ophthalmic conditions. So specifically today, we're going to talk about the importance of genetics in terms of the corneal dystrophies. Now, we've all known for a number of years that there are a number of conditions which affect the cornea, and they roughly divide into two groups. The groups which have an effect predominantly around Bowman's layer, and those which affect the deeper stroma. And the Avellino company has concentrated initially on these first 5 conditions. Now, it's interesting that all of these relate to anomalies generated in transforming growth factor beta-induced. So all of these have an involvement with TGF-beta. And we're lucky in some ways that they're all on the same chromosome, different positions slightly, and different anomalies in the gene pairs give rise to the different conditions we see. These are autosomal dominant diseases. And you can either have patients with homozygotic mode of inheritance, getting a defect from both of their parents. This results in a very early onset disease with very severe consequences for the cornea. But the ones that are of more concern are the heterozygotes, because in early life these may have very few manifestations and virtually none when they come to the clinic prior to refractive surgery. They have differences, which I'm sure Tony will talk about later, in terms of their histopathology and in terms of the underlying potential problem within the cornea. So in GCD type 1, the Avellino, type 1, we see a potential problem in between the stromal layers in terms of abnormal deposit, and in Avellino we see predominantly hyaline deposits, but sometimes a little amyloid, whilst in lattice it's predominantly amyloid. So up until now we've known the clinical picture, which is a bit confusing because they present with often very similar appearances, and we've known a little bit about the histology. But it's not until we've really got to terms with the genetics that we really began to understand what was going on. So if you think of the cornea simplistically, textbook picture, we have the epithelium, Bowman's layer, stroma, predominantly collagen in a matrix with a few cells, then Decimase membrane and endothelium. If we look at the stroma in detail, you can see the fibroblasts there, long elongate cells, a network with a degree of connectivity between the various stromal lamellae. We know that surgery will often cause a disturbance in corneal transparency, and this is an early picture of one of my group, Chris Lohman, who looked at, in a quantitative fashion, haze after PRK. Why did we get haze after PRK? Well, it was TGF-beta, and it was caused by taking the epithelium off and at the same time damaging epithelium and underlying stroma. If you do that, you have signals released from both the rejuvenating epithelium and the changing keratocyte population in the choroid, and these two come together producing haze. And I've flashed a warning there in the granular dystrophies for the heterozygotes. In this country, most of you that do refractive surgery will be using LASIK, and the beauty of LASIK was, in the early days, we saw very little haze because we had no signal from the epithelium. We only now had a signal from the stromal keratocytes. But all the work that my group and others have done on biomechanics have resulted in shallower and shallower and shallower flaps, and now, of course, the epithelium is very close to the underlying stroma, and we do see a transient haze, especially around the edge of LASIK. So if you disturb the lovely flat keratocytes in the cornea by surgery, you have activation of the keratocytes and release of TGF-beta. You have new collagen laid down, which is often not of the right type and certainly not of the right orientation. So again, we have a model in which we can take human donor corneas, do any sort of surgery, and look at the wound healing processes with confocal microscopy. And with PRK and LASIK, you do have a difference in the rate of transformation of the fibroblasts, but they will become activated and will give the potential for disturbances in corneal transparency. We're beginning to see some publications in the literature of accelerated changes in Avellino dystrophy and granular dystrophy after LASIK, and that's the warning that I want you to start with here at this meeting. So if you take a heterozygote with a virtually clear cornea and carry out surgery, not knowing that the patient has the genetic problem, you can accelerate and exacerbate their endpoint. And I think this is obviously very worrying because the patient starts with a reasonable cornea, don't know they have a problem, and you give them a very significant problem as a result of your surgery. That's why I'm a great advocate for the Avellino test. We can detect all of these dystrophies from just a buccal swab, and you'll hear more of that later. Don't tell me that these dystrophies are only a problem of Asia. They're not. They're pretty much worldwide, and the more that the company has been carrying out the tests, the greater the incidence of the disease. So finally, we can detect, we can prevent the disasters of operating on an inappropriate patient, and the future is even more exciting because we've already got some gene therapies underway, trials of recessive genes, but with the new CRISPR technology, we have the potential to treat autosomal dominant disease. So this is a very important finding for the future. So finally, we're 100 years after the First World War. The US had a poster, "We want you want Avellino, you absolutely don't want litigation." And this is the way to avoid it. Thank you.